This is the Cavitron FSI slimline right and left curve. They are used for fine periodontal debridement in deep pockets greater than 4 millimeters. Utilizing these inserts provides maximum access and adaptability to root anatomy, including concavities and furcations. These inserts should be used at low to medium power levels. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. When access is indicated in deeper pockets, in particular the posterior teeth, a curved insert is often necessary to maintain true adaptation of the terminal 2 to 3 millimeters at all times. A review of dental anatomy is recommended so the clinician is familiar with the topography of the different molars and the corresponding concavities and convexities. Understanding the area-specific design of these inserts is essential for proper adaptation. The clinician must be able to identify the inserts by recognition of the shank and direction of the curvature of the tip. Memorizing colors or trying to read the stacks can be challenging and prove confusing for the clinician. Adapting the curved insert properly requires a fundamental knowledge of the tooth's anatomy and proper placement on the appropriate tooth surface. In order to identify which insert one is holding, it is recommended to begin by holding the inserts parallel to the floor with the points facing down or perpendicular to the floor with the points facing away from the clinician. The right insert will curve to the right and the left will curve to the left. It is also helpful to place the insert on the occlusal of the intended tooth, as demonstrated here, to see the curvature to ensure you selected the correct insert. After this is established, maintain a vertical approach and notice that the back of the insert is adapted to the surface you are entering. Utilization of all surfaces is indicated for proper adaptation in periodontal pockets interproximally. Begin on the clinical crown, float subgingivally, riding the anatomy and clinging to the pellicle while always maintaining 2 to 3 millimeters of adaptation and no more than 15 degrees angulation. Navigating the pocket, assess while entering and engage any deposit encountered with a gentle tap. Frequent, methodical, overlapping strokes are essential in the periodontal pocket to detoxify and debride every square millimeter. A haphazard approach will leave deposit and biofilm behind and limit the patient's response to therapy. As the clinician proceeds towards the interproximal area, proper adaptation is achieved by staying with the anatomy and following the topography of the pocket. Once thorough instrumentation has been achieved, the clinician returns to the line angle and with a vertical adaptation proceeds with channel stroke across the buccal, allowing for tactile sensitivity to drive the stroke engagement. As seen here, the curved left insert is following the anatomy into the furcation and is maintaining the necessary 2 to 3 millimeters of adaptation. Proper adaptation is required to navigate the interproximal space successfully. A slight turn of the insert maintains adaptation around the line angle and assists the clinician to successfully debride the periodontal pocket. To debride the lingual surfaces of the quadrant, the clinician must switch to the left insert prior to beginning instrumentation. It is essential to remember that the contributors to root surface loss are excessive lateral force, incorrect angulation and adaptation, incorrect insert width, and excessive power. Any of these factors may result in root substance loss and create grooves for biofilm to attach. The curved inserts are ideal to reach under the contact areas supragingivally in what is known as the transverse approach, similar to using a Nevi or a 204S posterior sickle scaler. The curved inserts can be adapted to the mesial and distal surfaces utilizing the lateral surface of the tip. Note in this demonstration, the clinician is using proper adaptation for transverse approach, supragingivally under the contact.